السلام عليكم طلبتنا الأعزاء. اليوم نتكلم عن موضوع أو ناخذ جزء من العملي بجراحة الأنف والأذن والحنجرة. راح يكون مجموعة من حالات، تقريبا 6 حالات. كل حالة راح نتكلم عن موضوع معين يخص ENT practice. الحالة الأولى case number 1 30-year-old male patient with nasal obstruction hyposmia. Hyposmia means decrease in the sense of smell sensation or sense of smell. What is your first of all, what is your differential diagnosis and how to manage the problem? According to the picture below, you can see, I will describe you, this is anterior rhinoscopy with use of the nasal speculum on the left side. Okay, the picture on the left side demonstrate the use of the nasal speculum, and see there's a mass filling the left nasal cavity. On the right side, you can see here also there's a mass filling the right nasal cavity. Usually, in this case, when you see the both sides with nasal fullness with the mass and like polypoidal mass, usually the diagnosis nasal polyposis. But this is not a guarantee. Sometimes the nasal tumors, the sinonasal tumors, also comes in the bilateral disease, but this is a rare. Usually, nasal polyposis give us this picture. Okay. How to manage the problem? Usually, the nasal polyposis, it means that the patient will also there's edema of the nasal mucosa. The origin usually from the ethmoid sinuses, and also lead to the symptoms usually consist of, or according to the presentation of your patient, will be the nasal obstruction, sometimes presented with the headache, hyposmia or defect in the nasal smell sensation, and also postnasal drip, rhinorrhea, and so on. The treatment of nasal polyposis consists of the medical and surgical intervention. Medical treatment will be like topical steroid. If you suspect that the origin of the problem is the allergy, can give the anti-allergic therapy, such as can add antihistamine. Also can use systemic steroids to decrease the size of the nasal polyps. And then if all of these fail, then you can do the endoscopic sinus surgery. The nasal polyp is considered a common problem in our practice, and the management is not easy because the nasal polyp can take all the sides of the paranasal sinuses. It can extend from the ethmoid and anterior osteometal complex to extend to the maxillary sinus, to the ethmoid, to the frontal, and even to the sphenoid sinuses, and can also present the nasal polyp as a part of another diseases, such as an allergic fungal sinusitis. So you have to diagnose very well and then start the treatment. The next patient with nasal obstruction, chronic headache. Below image give you a clue about the offending cause of the problem. In such a case, if you inspect the pictures in the right or the left, you can see the right side there is a nasal deformity, external nasal deformity, which is due to the deviation of the nose to the left side of the face of your patient. While in case of on the other side, in the left picture, you can see here the caudal end of the nasal septum dislocated from its normal side, and this is called the dislocation of the nasal septum. This indicates that the patient have a severe nasal septal deviation. So the offending cause for the problem and nasal obstruction is what? Nasal septal deviation. How to manage your patient with nasal septal deviation? By surgical intervention usually. We call it the septoplasty. And the septoplasty means that will be elevate the mucoperichondrium from the both sides or one side, according to the preference of the surgeon, from the cartilage and bony part of the nasal septum. As you know, the nasal septum consists of two main parts. Anteriorly is a cartilage, posteriorly is a bone, and the bone consists of 4 bones mainly: perpendicular plate of the ethmoid, and the vomer, and also from the palatine bone and maxillary crest. Also give uh, the part or the participate in the bony part of the nasal septum. Therefore, sometimes there's a deviation in these parts, or the junction between the cartilage, or the deviation in the cartilage itself, or the junction between the bony and cartilaginous aspect of the nasal septum lead to the dislocation or deviations. And usually this is, according to this case, or this case usually, I think it's mainly due to external previous trauma. Number 3, 40-year-old male patient with hoarseness. Direct laryngoscopy. Give this picture shown below. This patient comes to our clinic or to our outpatient clinic. He complains of the hoarseness, and the endoscopic assessment was done to him or performed, and like fiber optic laryngoscopy or stroboscope, whatever the assessment. المهم يكون direct vision to the laryngeal inlet and see these two masses in the vocal cord, mainly the posterior aspect of the vocal cord. This is usually due to irritation of the arytenoid cartilages of the vocal cord, and this will lead to what you call the tubal or vocal cord granuloma. The important thing you have, number one, what are the important questions do you want to ask the patient؟ من الاسم احنا نقول عنها vocal cord granuloma or tubal from the tubal granuloma. That's mean the patient was on call the endotracheal intubation was done to your patient. There's some history of the recent surgery، يعني مريض محتاج لعملية أو دخل للآي سي يو وتسواله endotracheal intubation. This tube usually can lead to the pressure over the arytenoid cartilage and lead to the necrosis and erosions of the mucosa over the arytenoid, and replaced with inflammatory reaction lead to the granuloma formation both sides of the vocal cord over the arytenoid, as a picture on the right side. How to manage your patient usually؟ طبعا مناسبة the left side picture, it is intraoperative direct laryngoscope picture, and this is will prepared for the surgery. Usually that management is conservative. Main things, speech therapy. You can use also the medical therapy such as give the anti-GERD, gastroesophageal reflux disease management, because some of the scientists believe that the cause is the two GERD, phenytoin proton pump inhibitors, and avoid also advise your patient to avoid the spicy foods and so on, irritant smell, smoke, avoid smoking and so on, avoid alcohol also. The management, sometimes even we will reach to the surgical intervention such as the CO2 laser therapy, but the main thing is the conservative management, and the better thing is the avoid the pressure by the tube itself in the laryngeal inlet to prevent such as complications. Fourth case is a 50-year-old female patient with left otalgia, otorrhea, and oral fullness. What is your professional diagnosis? From the picture below, I see here the entrance of the ear is edematous, and this edema swelling in this age group, you can think about the we call the otitis externa. واضح? And how to treat the problem? Usually the otitis externa, we have a many type: mild, moderate, or mild to severe cases. In mild, we means that the lumen of the external auditory canal is not occluded, while when there's severe stenosis of the external auditory canal, we call the severe otitis externa. Why this is the classification? Because the management is different. In such a case, like this woman, we can use just ear drops, antibiotic ear drops, sometimes mixed with steroid. In addition to that, we can give also systemic antibiotic and tell the patient avoid water entrance to her ear, infected ear. Why? This will be enhance the bacterial proliferation the water. أي مكان رطب راح يكون أكيد proliferation of the bacteria and fungal disease. So avoid water exposure or entrance to your ears, to the ear of their patient. How to treat the problem? Usually the problem can be treated with, as I said, with antibiotic therapy, topical mainly antibiotic. Sometimes such a patient who comes to you with immunocompromised status, like in patient with renal dialysis, chronic renal failure, blood disease malignancies like leukemia, lymphoma, or AIDS, HIV infection, or most commonly with diabetes patients, or patients exposed to the radiotherapy in this region will have a special entity of the otitis externa. We call it the necrotizing otitis externa, or sometimes called it malignant otitis externa. And this is the difference in the management. Patients should be treated with aggressive antibiotic, topical and systemic antibiotic. Usually the cause in both sides in كانت ordinary classical otitis externa, or in patient with malignant otitis externa, usually the microorganism gram-negative Pseudomonas, mainly. Sometimes fungal disease lead to both of sides, both the diseases, like aspergillosis, okay, can lead to the or candidiasis, also can lead to the classical otitis externa, or sometimes even the aspergillosis can lead to the, especially in immunocompromised patient, to the malignant otitis externa. The treatment should be systemic antibiotic or topical antibiotic and local debridement to the site of the lesion in the external auditory canal. Fifth case, 30-year-old patient with head trauma. CT scan of the temporal bone show you abnormality. What is the radiological finding? In the left side picture, we see the CT temporal bone, and there is a fracture in the roof of the external auditory canal. We call the longitudinal fracture of the temporal bone. And this fracture usually sometimes associated with the CSF otorrhea, and even sometimes with a rupture of the tympanic membrane and ocular disruptions. واضح? The next picture is the midline. There is a blood behind the tympanic membrane. We call hemotympanum because of the trauma to the roof and a collection of the blood inside the middle ear cleft or middle ear cavity. واضح? The other side, or the other picture, the right side picture, we can see here the sign, which is not any common to be seen, is the bluish discoloration post auricularly or behind the ear over the mastoid area. We call it the battle sign. Battle sign is the sign due to the collection of the blood below subcutaneously due to middle cranial fossa injury. So the patient will have temporal bone fracture due to trauma. واضح? This is the most important, one of the most important pictures in these cases, because we have three signs. One of them in the middle, hemotympanum, and the other battle sign, and CT temporal bone show you the fracture, longitudinal fracture of the temporal bone. The last case, this is the traditional cases in the ENT, real young patient with facial trauma. What is your diagnosis؟ واحد عنده صار facial trauma. شنو موجود بالبيكتشرز نشوف؟ very easy is the deviation of the external nose towards the other side. This is called the fracture nasal bone. What is your management? Patient in such a case, especially in the left side, the picture, you see there's an edema of the nose. This should be subsided. Usually the golden period 5 to 7 days to subside the edema of the nose, external nose. Then you can start your treatment and management to your patient, usually by close reduction of the fracture nose. This is done by use a special instrument under general anesthesia. We call the Walsham forceps. Return back to the nasal bones towards the midline and put the POP, external POP, plaster of Paris, for 7 days, and then removed. وحيصير إن شاء الله healing بالنيزل بونز ينتهي الموضوع. What is your management? What are the complications? Sorry, complications متوقعة بالنيزل بون trauma. One of them is nasal deformity. Number two, nasal septal hematoma. Septal hematoma is considered as one of emergency in the nasal surgery. It should be drainage within at time of diagnosis, because this will lead to the necrosis. If you left the nasal septal hematoma, lead to the cut off of blood supply to the nasal septum cartilaginous, and this will lead to the necrosis of the nasal septal cartilage with nasal septal deformity and external deformity of the nose. So you can manage it easily with the simple drainage, incision and drainage of the hematoma, and put a pack inside the nose and to prevent recollection of the blood. واضح؟ What are other complications؟ طبعا أكيد trauma راح يكون عندنا من ضمنها epistaxis، قد يكون infection to the site. Sometimes hidden infection due to trauma inside the nasal cavity will lead to what they call the cavernous sinus thrombosis, septic thrombophlebitis or thrombosis of the cavernous sinuses. And this is one of the of the life-threatening complications of the nasal infection. حتى boils in the nasal cavity, especially in acute vestibulitis, can lead to this complication اللي هي septic cavernous sinus thrombosis. فلا تستهينون بالنيزل كافيتي انه ما الانفكشن بها مو خطر، لا. بعض الباثولوجي وان كان simple, especially in special circumstances of your patient, like patient with diabetes, patient عنده renal failure ومسوي renal transplant وماخذ immunosuppressant، هذول يكونون at high risk in this type of infection. It's easy to reach to the cavernous sinuses and lead to septic disease or pathology in the cavernous sinuses. شكرا، وإن شاء الله التوفيق لجميع طلبتنا.